My dear students, in continuation with the series of lectures on cranial nerves, today I will be taking up the second cranial nerve, the optic nerve. And this nerve is also important from a clinical viewpoint. And many questions are asked in your examinations about the optic nerve. Now we will be dealing with the cranial nerve as far as its course is concerned, as far as its important surgical relations are concerned, and the clinical correlates thereof. Now you can have a look at the board, and just as I mentioned, topic of the day, optic nerve, which is the second cranial nerve. Now you can concentrate towards me and have a look towards me, and you can well be assured that I will be telling you some of the important facts which you will not have come across about the optic nerve. Number one is that you already know that it is the nerve of the vision, but one important fact is that this optic nerve is different from other nerves in the fact that other cranial nerves, in the fact that there are the meninges, and usually meninges are associated with the brain and the spinal cord. Optic nerve happens to be one cranial nerve which has got meninges associated with it, and any inflammation and infection of the meninges of the brain can also be transmitted to the optic nerve as well. Second thing is that this optic nerve lacks a neurolemal sheath, as a result of which it cannot regenerate. So sight once gone as a result of damage to optic nerve is gone forever in most of the cases. Then the third important point which I would like to mention here is that we have got the optic canal. From the orbit, the optic nerve exits the orbit through optic canal, and in the optic canal it is in close contact with ophthalmic artery. So optic nerve and ophthalmic artery travel within the optic canal, and there's an important correlation why I mentioned it at this point of time, which I will be coming at the end of my class. So remember that optic nerve and ophthalmic artery travel together in optic canal. So any cranial nerve, having a look at the board now, you can have a look that any pathway should have a receptor, should have a pathway, should have a nucleus, and should have a center. So in a similar manner, as you can have a look at the board, you can have a look at the board again, and you will see that this represents the course of the optic nerve. Optic nerve exiting from the optic canal, forming optic chiasma, then forming the optic tract, then the optic radiation. And this terminology is to be well remembered. What we mean by the optic nerve, what we mean by the optic chiasma, what we mean by the optic tract, and what we mean by the optic radiation. So very important. Optic nerve, it continues, and the place where the two optic nerves cross is a sort of a crossing, and that is optic chiasma. And this optic chiasma lies in relation to the pituitary fossa. So a relation of pituitary gland in relation to the optic chiasma is important, which I will be talking about subsequently. And then from the optic chiasma there is the pathway which continues in the form of optic tract. And why does this optic tract go? It goes into a special part behind the thalamus, which we give the name as LGB, lateral geniculate body. Lateral geniculate body is one of the centers wherein the optic tract ends, and from the lateral geniculate body, which lies behind the thalamus, it has to go to the cortex. And what part of the cortex? The occipital cortex. And what do we call that special part? The calcarine part of the occipital cortex. So the part of the optic tract from the geniculate body, especially the lateral geniculate body, to the visual cortex is given the name as optic radiation, or we also give it the name as geniculocalcarine tract. Why? Because it originates from the lateral geniculate body and ends in the calcarine cortex. So geniculocalcarine tract. So we remember this whole optic course as optic nerve, optic chiasma, and then the optic tract, then the optic radiation or the geniculocalcarine tract. Now, this is something important about the optic pathway. So we have the receptor cells in the optic nerve, we have the pathway to the thalamus, we have a nucleus in the thalamus and a radiation and a sensory area in the cortex, which is given the name as visual cortex, or the previous classification according to Brodmann, area 17, area 18 and area 19. Area 17 being the primary visual cortex, area 18 and 19 being the associated areas. Now going back to the figure, you can have a look. Over here you have to remember that there are two visions. One is the nasal part of the vision and one is the temporal part of the vision. The nasal part of the vision refers to the medial parts of the vision of the two eyes, and the temporal part of the vision refers to the lateral part of the vision of the two eyes. Now basically you can see that the temporal part and the nasal part are represented diagonally opposite in the eye. Now having a look at the optic pathway. As far as the optic pathway is concerned, because first of all we have the optic nerve. If there is damage to the left side optic nerve, it will cause damage in the left side, and it can lead to blindness on the left side. If there is damage to the right side of the optic nerve, it will lead to the blindness of the right eye. As simple as that. So destruction of the optic nerve leads to damage or blindness of vision in the corresponding eye. Now we switch our focus back to the board. Now you can see there is the optic chiasma, and I just mentioned you that the optic chiasma is in relation to the pituitary gland, and in case there is a growth of the pituitary gland, it can compress upon the optic chiasma, as a result of which there will be a unique vision loss, and that vision loss we refer to as bitemporal hemianopia. That means the temporal sides of the vision of both the eyes is lost. Bitemporal hemianopia, bi, two, temporal on the lateral sides, hemianopia, and that is loss of vision on the lateral sides. So there will be loss of vision on both sides of the eye on lateral parts. Now then the lesion which destroys the optic radiation will lead to right homonymous hemianopia, that the right sided vision of both the eyes will be lost. So specifically right homonymous hemianopia. Now as far as the damage to the brain is concerned, I told you the primary area 17 is the primary visual cortex, area 18 and 19 are the associated areas. So what can happen if there is damage to area 17? There can be loss of vision of the corresponding part, complete loss of vision. And in case there is damage to area 18, the damage to area 18 can cause peculiarly what a patient can see but cannot recognize what he sees, and this is called as mind blindness. Patient's capability to see but not able to recognize what he sees is called as mind blindness. Then damage to area 19 especially causes word blindness, that the patient is able to recognize the objects but cannot recall their meaning. This is very important. So this is called as word blindness. So blindness can be of three types: complete blindness, loss of sight, mind blindness, and word blindness. These are some of the very important peculiar facts which you have to remember about the optic nerve. In addition to that, optic nerve and ophthalmic artery travel together, and any tumor of optic nerve glioma, can compress the ophthalmic artery and cause decreased blood flow to the eye. I hope that these points are important as far as the optic nerve are concerned. So just remember this topic and these points very nicely, and I wish you that you just complete the optic nerve revision completely. Thanks a lot.